Hi everyone, I'm Sensuka, and I'm going to be going through the GP matrix topics for endocrinology, metabolic disorders, and neurology. So, as part of this session, we'll go through some questions and the content related to those questions, and then I'll discuss the answers as well. So, I'd like to thank William Kin, Nezim, and previous PSPs and MUMIS revision lectures, which have helped me make the slides for today. So, let's start off with endocrinology. As part of the endocrine and metabolic disorder matrix, there's all R1s, but it's also important to note that some conditions in the year 3 matrix aren't included in the year 4 GP matrix, but are still important for you to know for the GP exam. So, for example, conditions related to adrenal insufficiency or Cushing syndrome, which aren't included in here, are still important for you to know. So let's go through a few questions. Question 1. A 52-year-old male presents with a BMI of 31 and hypertension and is found to have a fasting blood glucose of 6.8 and HbA1c of 6. He's asymptomatic. What is the most appropriate initial management step? So pause, go through the answer, and then I'll tell you the answer at the end. Next question. A 68-year-old patient with type 2 diabetes is on maximal tolerated doses of metformin and glycoside. His last two HbA1c results were 8.1 and 7.9%. He has established cardiovascular disease. What is the most appropriate third-line oral or injectable agent to add? And then a 22-year-old female is newly diagnosed with type 1 diabetes and requires an insulin regimen. Which of the following is the standard most appropriate initial regimen to mimic physiological insulin release? Okay, so diabetes. There's a lot of different types of diabetes, but the main two types are type 1 and type 2, where type 1 diabetes is characterized by the failure of insulin production by the pancreas, and type 2 diabetes is related to insulin resistance from the body. There's a few key clinical features associated with diabetes, including polyuria, polydipsia, and polyphagia, fatigue, and especially with type 1 diabetes, weight loss. Complications of diabetes can be broken up into macro and microvascular complications, with microvascular complications including neuropathy, nephropathy, and retinopathy, and macrovascular complications including cerebrovascular disease, cardiovascular disease, and peripheral vascular disease. So investigations for diabetes include looking at blood sugar levels, either acutely or with HbA1c, which is the average of 3 months of blood sugar levels. So with acute types of blood sugar levels that we can look at the fasting blood glucose, random blood glucose, or in pregnancy, we can look at the 2-hour OGGT. Important to know is the values associated with normal blood sugar levels and abnormal blood sugar levels. With abnormal blood sugar levels, if the sugar is more than 7 or more than 11, so more than 7 for fasting and more than 11 for random, then this is considered to be abnormal. But just having one of these results by itself isn't enough to make a diagnosis of diabetes, which we'll come to here. If they have a HbA1c reading of more than 6.5%, then this can indicate diabetes as well. And target treatment level is less than 7%. So, as I mentioned before, just having abnormal readings here isn't enough to make a diagnosis, especially if they're asymptomatic. So if a patient is asymptomatic, so it doesn't have any clinical features of diabetes, then we need to have two separate abnormal readings. So two of these readings need to be abnormal. If they're symptomatic, then only one abnormal reading is required to make a diagnosis. It's also important to consider secondary causes of diabetes. So conditions related to pancreatic failure, including chronic pancreatitis, cystic fibrosis, or hemochromatosis, or conditions related to insulin resistance, including PCOS, Cushing syndrome, or acromegaly, as well as looking at any medications that they can be on, including steroids, or thiazide diuretics. With diabetes, screening is really important because diabetes is so common, especially in certain populations, but generally in Australia as well. So, screening for diabetes begins at the age of 40 years old, and we can do a risk calculation through the OSDRISC calculator. If they have a score of more than 12, this indicates high risk. So, based on the risk stratification, we want to consider doing either Ostrisk every 3 years if they're more than 40 years old, or more than 18 years old if they're Aboriginal or Torres Strait Islander. If they have an Ostrisk score of more than 12, or have some of these high risk group features, then every 3 years we need to do a fasting blood glucose or HbA1c. And if they're pre-diabetic, then every year they need to be their blood sugar levels need to be tested. Once a diagnosis of diabetes is made, then we can start the patient on monotherapy on sugar lowering medications. So typically patients will be started on monotherapy of metformin. Other medications such as sulfonylureas or insulin are less commonly used as first-line medications for type 2 diabetes. Sulfonylureas are less commonly used now because of their hypo risk, and insulin is often used later down the line if other medications don't work for type 2. For type 1 diabetes, as you'll go through in pediatrics, insulin is the first-line therapy. So, if metformin doesn't work or if it's contraindicated, then we can consider other medications, including SGLT2 inhibitors or GLP-1 receptor agonists. If they have cardiovascular disease or heart failure, SGLT2 inhibitors are the first line of call. Also, if they've got CKD. If they're overweight or also have cardiovascular disease, GLP-1s can also be considered. Later down the line as well, we can consider adding more medications to the list and seeing if this can reduce their blood sugar levels. So important for the exam is knowing the key side effects and contraindications of diabetes medications. So metformin, the key contraindication is lactic acidosis and renal failure. Side effects include GI disturbance. Metformin is a weight neutral medication. SGLT2 inhibitors can need to be put on caution if the patient is using other diuretics, because SGLT2 inhibitors have a diuretic effect as well. Side effects that are important to know are UTIs and euglycemic ketoacidosis. GLP-1 agonists are contraindicated if the patient has had pancreatitis, and side effects can include pancreatitis or GI disturbance, and in a good side effect is weight loss. So a patient can present with high blood sugar levels or with low blood sugar levels, especially if they're on medication. Hypoglycemia is where the blood sugar levels are less than 4, and they can present with symptoms including adrenergic symptoms of pallor, diaphoresis, tachycardia, palpitations, visual disturbances, or headaches. Especially with type 1 diabetics, patients might have hypoglycemic unawareness. So this is where they don't know that their blood sugar levels are low, especially if they've had repeated episodes of hypoglycemia. Management for hypoglycemia include giving them some jelly beans or orange juice or high sugar drinks if they're conscious, and then giving them some longer lasting sugar sources, so like a loaf of bread. Sorry, not a loaf of bread, a slice of bread. And then if they're unconscious or unable to tolerate oral forms of increasing sugar levels, then glucagon 1 milligram IM can be used. DKA is a condition that you'll go through in detail in pediatrics, but the key thing to note for GP setting is that we need to refer them immediately to ED, as they'll require a lot of fluid and close monitoring. So, the answer to the questions that we went through before, answer to question 1, most appropriate initial management step for an asymptomatic pre-diabetic patient is a structured lifestyle program with weight reduction and regular physical activity. So before giving them medications, you want to try a lifestyle modification. Question 2 was about metformin and glycoside, which wasn't managing this patient's type 2 diabetes effectively. So we want to aim for less than 7% of their HbA1c, and that hasn't been established. So we can add on an SGLT2 inhibitor because the patient has established cardiovascular disease. GLP-1 can also be considered, but it's not one of the options here, but that can be considered as well. Then our 22-year-old patient with type 1 diabetes is more of a physiology question, and the most similar to the normal physiological insulin release is with basal bolus regimen. Okay, now moving on to high cholesterol. Let's look at this patient, who's a 50-year-old female who presents for a routine checkup. Her total cholesterol is 6.1 and LDL is 3.8. She's a non-smoker with no known cardiovascular disease. What is the most appropriate initial management step? Next question. A 62-year-old male presents 6 months after MI. He's on atorvastatin 40 milligrams daily, aspirin, and an ACE inhibitor. His LDL is 2.4. What is the most appropriate next step in his dyslipidemia management? Okay, so Asha will have gone through this. So in one of the other presentations, looking at preventative health, and high cholesterol plays a part of that. But let's just have a quick revision. So with high cholesterol levels, we can look at, it's important to know these values and try and memorize them for the exam. So abnormal levels and what we want to aim for primary prevention. So if the patient has high, abnormal levels, we can look at their LDL, triglycerides, and total cholesterol. So this is the total of these two. Of course, there's other factors as well, but we'll look at these two mainly. So if their LDL levels are more than 3.5 and tags are more than 2, the total cholesterol, if more than 5.5, this is considered to be abnormal. With primary prevention, we want to aim for less than 2 for their LDLs, less than 2 for their triglycerides, and less than 4 for their total cholesterol. So management for high cholesterol or dyslipidemia include first line of statins. So there's lots of different types of brand names for statins, but it's the first line medication that we use. There are some side effects associated with statins, including rhabdomyolysis and muscle weakness. Hepatotoxicity can also be present, but in most patients, this effect is not very common. They might have some mild muscle weakness or pain, especially at the start of taking medication, but in most patients, this won't be severe. So then there are also a bunch of second line medications that we can also use. The main thing to note is for management of hypercholesterolemia or hyperlipidemia, we often want to increase the dose of statins before we try adding another medication. So this is dissimilar to high blood pressure or hypertension, where we, rather than increasing the dose, we'll add another class. With high cholesterol, we'll increase the dose until it's the maximal dose, and then we can add other medications. So going back to the questions, question 1, this patient has high total cholesterol and high LDL as well. So going back to here, we can see LDL is 3.8, so more than this, and 6.1, sorry, which is more than this. But she's a non-smoker with no known cardiovascular disease. Initially, you want to do a cardiovascular risk assessment. And the reason for why that's the first step is because if it's less than 5%, we want to encourage lifestyle modification. If it's more than 5%, that's when we'll start with a statin. Question 2 goes back to the point that I was mentioning before, where we want to increase the dose of statins before trying a different class of medication. So in this patient where they've started on 40 milligrams of atorvastatin, but their LDL is still not below what we want it to be, which is below 2, then we want to increase the dose of the statin. Okay, moving on to thyroid. So a 45-year-old male is started on carbimazole for Graves' disease, which is the single most critical and urgent safety instruction the GP must give the patient regarding potential adverse effects. Okay, so thyroid, we have hyperthyroidism or hypothyroidism. So hyperthyroidism is associated with a fast body system. So they get weight loss, increased appetite, heat intolerance, tachycardia, palpitations, arrhythmias, diarrhea. You might feel quite jittery and nervous, and they can be quite sweaty. Whereas with hypothyroidism, it's a slow body system, so they get weight gain with decreased appetite because their metabolism is slow, cold intolerance, braddy, constipation, fatigue, mental fog, dry skin. So, causes of hyper and hypothyroidism I've listed here. Um, the most common cause of hyperthyroidism is Graves' disease. Um, and it's important to know that declinated thyroiditis can present as hyperthyroidism and then progress to hypothyroidism. With management of hyperthyroidism, we can give them a range of medications, but typically we'll start them on carbimazole, or if they're pregnant, propylthiouracil, PTU. Radioactive iodine can also be considered, and thyroidectomy can also be considered. Hypothyroidism, we want to replace the thyroid hormone, so levothyroxine can be given. So going back to the hyperthyroidism medications, carbimazole and PTU have two key side effects of agranulocytosis and hepatotoxicity. So agranulocytosis is a significant side effect and quite a severe side effect to be aware of because the patient can have a significantly high infection risk. And that comes back to this question here, where this is the safety instruction the GP must give the patient, where if they develop a fever, sore throat, or mouth ulcer, this can be because of agranulocytosis. Great. Next, we've got a patient with osteoporosis. So which following pharmacological agent is considered the first-line treatment for a patient with a new diagnosis of postmenopausal osteoporosis with a T-score of -3 and no history of gastrointestinal issues? So osteoporosis diagnosis can be made in two ways. The first way is if they've had a minimal trauma fracture, um, if they're more than 50 years old, or if they have a DEXA scan, which shows a T-score of less than -2.5. If they have osteopenia, which is pre-osteoporosis, then they'll have a T-score between -1 and -2.5. Other causes of osteoporosis, so they might have secondary causes of secondary osteoporosis. So other investigations, which I've listed here, are important to consider. Management of osteoporosis is a common OSCE or APEX station, but it's also important to know for your exam. So non-pharmacological management includes fall prevention, strengthening exercises, limiting smoking and alcohol, and reviewing medications that can increase the risk of falls. Just psychotropic medications or antihypertensives can result in falls. So it's important to consider those. Then we have a lot of different medications for pharmacological management, but the two main ones to consider are bisphosphonates and denosumab. So there are other medications as well. It could be good for you to go through the method of action of osteoporosis medications um, and the key side effects, which I've listed here. So with bisphosphonates, the main side effect is esophagitis, so the advice for the patient is to take the medication before the meal and remain upright for 30 minutes. You can take the medication for 5 years and then take a drug holiday because the benefits last for 1 year after stopping the medication as well. Adverse effects include TMJ necrosis and atypical femoral fractures. Denosumab is another common medication which can be used. So, with this patient, first line in a patient who is postmenopausal, no history of gastrointestinal issues, is bisphosphonates. Sometimes patients might opt in for a denosumab injection as well. So, last endocrine condition on the matrix is obesity. It's not a commonly tested condition, but what they can go through is maybe some diagnostic criteria. So obesity is where their BMI is more than 30 and their waist circumference is more than 102 centimeters for men and more than 88 centimeters for women. Management of obesity largely revolves around lifestyle advice, but medications or bariatric surgery can also be considered. GLP-1 receptor agonists, Ozempic, is a medication that's all over the news right now, and that's can be really helpful for weight loss. Okay, so now moving on to neurology. Here are the conditions that we will go through today. Again, make sure you go through the matrix for year 3 to see if there's any discrepancies or anything that isn't listed here, and try and go through those as well. Okay, first question. A 30-year-old accountant has been diagnosed with episodic migraine without aura. She reports 8 to 10 headache days per month, with attacks lasting 12 to 24 hours. She's currently managing her migraines with over-the-counter ibuprofen, but it makes her feel sick. According to Australian guidelines, what is the most appropriate reason to initiate migraine prophylactic therapy? Okay, so with migraines, there's often a timeline or a typical way in which migraines can present for patients. So here's there's 6 phases that they've listed, but the key ones to know is often patients will have a migraine, so an aura prior to their migraine. So this can be visual or sensory auras. So visual disturbances might include that they notice um, like zigzag lines or blind spots in their vision. And as I mentioned, visual disturbances are the most common type of aura. But only 1/3 of people with migraines experience aura. Then the acute phase of the migraine is characterized by severe pulsating unilateral headache with associated photo or phonophobia and nausea or vomiting. After the migraine, the patient might have a migraine hangover or a post-stroke phase, which is where they feel really tired, depressed mood. They might have some brain fog as well afterwards. There's a few common triggers for migraines, which you can go through here as well. So management for migraines is, if non-pharm, is we can put them in a dark, quiet room. Neck physiotherapy can be quite helpful. Heat packs or cold packs over the neck, shoulder, or head. And acute treatment includes antiemetics, analgesia with paracetamol or NSAIDs, or triptans or glutamine, is helpful for patients. It's important to note that if the patients are getting like using these medications more than 2 to 3 times per week, to have some caution about this, because they can then go on to have medication overuse headaches as well. So, indications for prophylactic treatment of migraines is if they have more than 3 migraines per month. And we can use medications including antidepressants, anti-epileptics, or antihypertensives. There's also other types of headaches which are good to know about for the exam, including tension, sinus, and cluster headaches. So tension headaches are a band-like pain around the head, typically associated with stress. Cluster headaches happen at certain times of the year with severe eye pain and nasal discharge from one side, so lacrimation from one side. Management for cluster headaches is with oxygen therapy and triptans. With sinus headaches, the STEM in the exam might mention the patients had like a runny nose and some upper respiratory tract infection symptoms, and now they've got this headache. And management for this includes decongestions, or if it's bacterial sinusitis, then antibiotics. So going back to the question, prophylactic therapy for migraines is if they have more than 3 headaches per month. Next, we go on to meningitis. So the question is about a GP who manages a confirmed case of meningococcal infection in a 6-year-old child. The child's 3-year-old sister is asymptomatic but in close contact. What is the most appropriate post-exposure prophylaxis? So meningitis can be because of different etiologies. Most commonly, it's because of bacterial causes, but it can also be, most commonly it's because of viral, but what we'll see in the exam mainly is bacterial meningitis. It can also be because of TB or fungal infections. There's lots of different types of, lots of different causes of meningitis. You'll go through meningitis in quite a bit of detail in pediatrics. and in women's health as well if it's neonatal meningitis. But the main organisms to know about are H. Haemophilus influenzae and Neisseria meningitidis. Streptococcus pneumoniae is also a common cause of meningitis. So patients with meningitis will often present with a triad of neck stiffness, fever, and altered conscious state, and headache. Nausea and vomiting is also quite common. If they have seizures or focal neurological signs, then encephalitis should be considered as well. If they have a non-blanching purpuric rash, then you want to be really concerned because this could be meningococcal. So, examination for meningitis, we have two different tests, Brodzinski's and Koenig's. So, Brodzinski's sign is where the B stands for you bend the neck, and this causes the patient's hip and knees to flex. With Koenig's sign is where you can't extend the knees because of pain, so that neck might flex, and this is when the hip is flexed to 90 degrees. Okay, so meningitis investigations, you want to do a blood culture, a septic screen. In a GP setting, you're sending this patient immediately to hospital. Lumbar puncture we'll go through as well, but this can show up mainly in other exams. So I've put this table here. Have a look through, make sure you know what the changes are. So in a GP setting, like I mentioned, you want to refer them immediately to the ED. If you're suspecting meningococcal disease, then IV benpen or ceftriaxone can be given. Bacterial versus viral. Viral is more common than bacterial meningitis, but it's often less severe than bacterial meningitis. Okay, so the answer for the question we went through before was oral rifampicin or a single dose of Cipro. So this is the post-exposure prophylaxis for meningococcal. Great. Next question. A 70-year-old male presents with sudden onset of right-sided arm and leg weakness with symptoms beginning approximately 4 hours ago. What is the single most important time-critical pre-hospital management step? So, strokes. Let's define it. Cerebrovascular accident or stroke is where they have abrupt neurological deficit lasting for more than 24 hours. A TIA is where they have a brief reversible episode of focal neurodeficits without infarction. It's typically lasts for less than 1 hour. Causes of strokes can be ischemic or hemorrhagic. If it's ischemic, it can be because of a thrombotic or embolic event. Hemorrhagic can be because of intraparenchymal bleed, subarachnoid hemorrhage, or berry aneurysm. I really like this flowchart because it goes through the assessment and management as well as follow-up for strokes or TIA. So let's go through it. So the common symptoms associated with strokes, we can think of the FAST acronym. So F stands for facial droop, A stands for arm or leg weakness, S stands for slurred speech, T is for time critical. So if they have features that make you concerned about stroke, then we want to look at this flowchart here, where we go here, yes. If the symptoms are currently present, then we want to consider this is more likely to be a stroke than a TIA. So if it's a TIA, let's go through that first. There's what we consider to be a high-risk TIA. And there's some key features here which make someone at high risk, having a high-risk TIA. So that includes age more than 60 years old, blood pressure more than 140. So if they have the clinical features of unilateral weakness or speech impairment without weakness, duration more than 60 minutes, or diabetes, then if they have a score of more than 4, then we want to consider that they could be at high risk of a TIA developing a stroke. So other things to consider is if they have AFib or a carotid bruit. Because the most common cause of a TIA is carotid stenosis. So in more than 50% of cases, it's associated with carotid stenosis. So primary care management, so in the GP setting, if a patient has TIA or if they're low risk, so that chance of developing a stroke is low, then you can arrange for bloods with FB, UEC, LFTs, glucose, lipids, and CRP. ECG, CT brain or MRI within the first first 48 hours, um, just to rule out any stroke, and carotid imaging, as I mentioned, because the most common cause is carotid stenosis. If they are at high risk of developing a stroke, then you want to urgently refer them to the hospital. Then, going back to here, if the symptoms are currently present or present for more than 24 hours, then you want to transfer them to the hospital immediately. This is a time-sensitive event because within 4.5 hours, we want to be able to do thrombolysis, and within 24 hours, you can do like surgical management with an endarterectomy. Okay, great. So here I've gone through the main different types of strokes. There's so many different ones. Good to just make yourself familiar with the key features of the different locations of strokes and how they present. Here I've listed the hospital management of stroke. Not relevant really for GP, but good to know about. Sorry, the main thing to know here is the secondary prevention post-ischemic strokes, where we can do antiplatelet therapy, so with aspirin and clopidogrel, beta blockers, anticoagulant if they have AF, and statins as well. Sorry, I might have mentioned before, with this one here, we can do clot retrieval within 24 hours. Yep, great. So going back to the question again, time critical is calling 000 immediately and notifying the hospital of potential stroke code. Especially because it's 4 hours ago, you want to get the patient to the hospital as soon as possible. Okay, then looking at head injuries, we have the three main types of head injuries, brain bleeds. So subarachnoid hemorrhage, subdural hematoma, and epidural. So subarachnoid is where the blood pools between the arachnoid and pia mater. And it's described as the worst headache of someone's life, thunderclap headache. Subdural is between the dura and the arachnoid. And this is often due to trauma. So a patient might fall, especially elderly patients, they might fall. And it's to do with the bridging veins. And this can be quite insidious. So they might get a worsening headache with time. Then with epidural, this is a form between the dura and the skull. It's to do with the middle meningeal artery and often related to trauma. The main buzzword feature is the lucid interval. So they might have really bad headache, then this goes away, then they get a lot worse and a lot more drowsy. So on imaging for subdural and epidural hematoma, subdural, sub-banana, looks like a banana. Epidural looks like a pie. So those are the key features on just familiarize yourself with what it looks like on imaging. So next question about seizures. A 30-year-old male has a witnessed single generalized tonic-clonic seizure. EEG and MRI are pending. What is the most important piece of advice regarding daily activities the GP must give this patient? Okay, so epilepsy. Definition for epilepsy is 2 or more unprovoked seizures that occur more than 24 hours apart. There's lots of different causes of epilepsy. It can be idiopathic or genetic. There's structural causes such as having a brain tumor, traumatic brain injury or stroke. Infections like meningitis or encephalitis can cause seizures. And metabolic causes like DKA can also cause seizures as well. Oftentimes, though, they won't have the diagnosis of epilepsy because of infection or DKA. So investigations for epilepsy include urinalysis and urine drug screening, BGLs and ECGs. For bloods, you can do FB, CRP, UECs, and alcohol levels if necessary, not as common in GP setting. Imaging, you can do CT brain or MRI, but the most important one is EEG. Management for epilepsy is really important to know for GP, especially at the end of the year for your apexes. So For management of epilepsy, you want to treat the cause of the seizure if possible. So if there's a reversible cause or something that is an acute cause of seizures, you want to treat that. Lifestyle-wise, avoid going in water, bodies of water, unsupervised. They also can't operate heavy machinery unsupervised as well. That's important to know is the driving restrictions as per Vic roads. So more than if they've had a diagnosis of epilepsy, then they can't drive for 12 months if they have a private license, or 10 years if they have a commercial license. For pharmacological management, focal seizures, there's a range of different medications, including lamotrigine, Keppra, carbamazepine. They have generalized seizures, then sodium valproate or Keppra, and absent seizures, then ethosuximide can be given. So for this question here, you need to inform the patient about his driving restrictions. Okay, last condition for neuro, MS. So a patient with established relapsing remitting MS presents with a severe acute relapse, manifesting as a significant new limb weakness and vertigo that is functionally disabling. All other causes have been excluded. What is the most appropriate management for the acute exacerbation? Okay, so credits to NESM. But here we can see the definition of multiple sclerosis, which is related to a chronic autoimmune disease caused by demyelination of the CNS, so damage to the myelin sheaths and oligodendrocytes, leading to neurological symptoms. So there's different courses in which the disease can take, including relapsing remitting, primary progressive, or secondary progressive. Your key buzzwords in the exam. So usually they'll give you a patient who's a young female with abnormal neurological symptoms. Typically, they'll give you optic neuritis. Important to know on MRI is, sorry, for investigations for MS, you can do an MRI brain and spine looking for sclerotic plaques. And you can also do a contrast MRI with gadolinium, so looking for acute flares of the MS. There is the McDonald's criteria for diagnosis, and as part of this, they have dissemination of their events with space and time. So dissemination space means 2 or more different sites of lesions causing symptoms, as seen on the MRI brain. Dissemination time is if they have 2 or more exacerbations 30 days apart. So this is important to notice. So like with MRI, you'll notice the multiple sclerotic plaques on the MRI, as well as a buzzword they can use is Dawson fingers as well. Typically, treatment for MS includes high dose IV steroids, as if they're in an acute flare. That's the first line. Long-term management include immunomodulators, biologic agents as well. So the answer for that question was high dose intravenous or oral corticosteroid. So that was a quick crash course of all the endo, metabolic, and neuro conditions. Hopefully that all made sense. This is all a foundational level of detail. So please go through in a bit more detail for some of these conditions as well. All the best for your exams. Good luck. And if you have any questions, feel free to contact me on Messenger. My name is Sansuka De Silva on Messenger. I'm happy to answer or give any advice for next year, moving into the future as well. All the best, guys.